Hi, I'm Jackie, and I'm going to be demonstrating several knee x-rays today. So the first thing that I would do is go over to my monitor and pull up my patient's name. And then the next thing that I would do is go find my patient. So, Evelyn?
Yes.
Hi. Can I get your full name and your date of birth?
Yes, it's Evelyn Valero, and August 19th, 1987 is my birthday.
And is there any chance that you could be pregnant?
No.
And what brings you in today?
Knee pain.
And how long have you been having the pain?
2 days.
Okay, all right, so just come on over here, and then if I can have you lay down on the table with your head at that end, please.
Okay.
Okay, and then once you lay down, I would go ahead and shield her. Okay, and then I would have my light aligned to the bucky, which it is, and it's detented at 40 inches. And then next I would want to make sure that my central ray is aligned to half an inch inferior to the patellar apex, which it is. And then I would also want to include in my collimation part of the proximal tibia and fibular bones, and then also part of the distal femur. And then I would go ahead and put my right marker down because it is her right leg. Make sure that it's all centered, which it is. Okay, and then I would go ahead and set my technique to about 65 at 5 for the AP knee. And then I would go ahead and take the exposure. Beep. Okay, so next I would do the medial oblique exposure, and I also had a 5-degree tube angulation on her knee to open up the joint spaces, and I would leave that angulation on there for the medial projection as well. So for this one, I'm going to have her rotate her leg 45 degrees medially, and then my collimation is still correct. I'm just going to have to move the central ray in a little bit, and I would do that by moving the table. So everything is already aligned. So once again, the central ray is going to be half an inch inferior to the patellar apex. And then once again, including part of the tibia and fibular bones and the distal femur. And she's still shielded. I have my marker, write my right marker down. I would keep the technique at about 65 at 5, and I would make the exposure. So, beep. And that is it for the AP and medial oblique leg exposures. Okay, so now we're going to be doing a lateral right knee. So she's already on the table. The first thing I would have her do is roll on to your right side, please. Great. And then if you could straighten your left knee or your left leg, and then bend your right knee 20 to 30 degrees, just like that. Okay, and then once she's in that position, I would go ahead and put the shield on her. Like so. Okay, and then once again, I want my tube to be at 40 inches. And I want to put a 5 to 7 degree cephalad angulation on it to open up the patellofemoral joint space. So I'm going to go ahead and do that. And then I want my central ray to be about 1 inch distal to the medial epicondyle. So since it's already lined up with my bucky, I am going to go ahead and just move her on the table to get the central ray right where it needs to be. And then once again, I would want to have it collimated a few inches below and above the central ray to make sure that everything is in the image. And then I would probably up my technique from 65 to 6 for this image. And then I would also mark it as her right knee. And then I would take my image. Beep. And that is it for the lateral knee. Okay, so now we're going to be doing a PA axial projection. It's called the Holmblad method, and it shows the intercondylar fossa. So right now I have the X-ray tube down as low as it'll go, and it's aligned 40 inches from the bucky, from the wall bucky. And this is a cassetteless room. So when you take an image, it goes directly from the image to the computer. I don't have to take out a cassette and change the cassettes. So I would have my patient put the shield on backwards because she is going to be facing the wall bucky. So it's going to go on like this. And then I would have her come up against the bucky and put her right knee all the way against the bucky, centered in the middle. And then if she, have her put her left leg back behind her and bending her right knee slightly. And then I would mark it with my right marker. And I would want my central ray to be going right into the patellar or the popliteal surface. So, should I make that? All right, so the central ray is going right through the popliteal surface, and then I want to collimate so that the part of the fibula and tibia are showing, and also the distal femur, like we did with all of the other knees. I would probably move my marker right. That's fine. Okay, and then I would probably set my technique at about 65 at 5, like I did for the other projections, and then I would take my image. Beep. And that is it for the PA axial home blot method. Okay, so now we're going to be doing the AP axial intercondylar fossa projection, and it's going to be the Baclair method. So the first thing I would do is the patient's going to be laying on the table, and then I would go ahead and have them bend their knee like that. And then the IR needs to be closer to the knee. So I'm going to go ahead and put this box down here to elevate the IP. And then I'll stick it under there like that so that it is closer. And then of course I would shield my patient. And I would want the shield to kind of go in between her legs to shield her gonads. And then my tube is going to be detented at 40 inches, but then it also needs to be angled so that the tube is perpendicular to the lower leg. So it is about perpendicular right now. And then I want my central ray to go half an inch inferior to the patellar apex, so right about there. And then I'm going to go ahead and mark my IP with my right marker because it is her right knee. And then the technique that I would use for this would be about 65 at 4. And then I would go ahead and take my image. Beep. Okay, and then I would have to, since this is a tabletop, this is not DR, I would have to take my image and go to the computer, scan it, and run it to get the image. So the next projection, I'm going to be doing the Setagast method, which is the AP patellar projection, tangential projection. So for this one, I am going to leave her leg in this position, except for this time she is going to be holding the IR against the back of her knee. So it's going to be like this, and then I'm going to ask her to hold it, and I will again mark it as my right knee. And then for this one, the tube is going to have to be angled up towards the knee at about 15 to 20 degrees. So I have to pull it back down as far as it will go. And then angle the tube up at her knee. And then the central ray should be entering at the patellofemoral joint. And I would probably use the same technique, which would be about 65 at 4 for this tangential projection. And then I would go ahead and take my exposure. I want it to be a little more angled. More like that. Okay, so I'd go ahead and take my exposure. Beep. And then once again, I would have to take the IP and manually stick it in the reader to get the image. And that is it. Okay, so now I'm going to go over the projections that I just took, starting with the AP knee. Here's an image of the AP knee. In the image, you should be able to see the intercondylar eminence, and then the patella should be superimposed over the distal part of the femur, so you shouldn't be able to see it very well. And then right here, you also should see the fibula partially superimposed over the tibia. And then next, I have the lateral knee. In the view of the lateral knee, you want to see the femoral condyles superimposed over each other. You want to see the patella to the side, and then you should also be able to see the space between the patella and the femoral condyle. And then for my next projection, I have the sunrise patella. For this projection, there isn't much to see other than the patella and the patellofemoral joint. And then for the next view, I have the AP or the PA axial intercondylar fossa view. So this, in this image, obviously, the most important thing is that you want to see an open intercondylar fossa. You also will see the intercondylar eminence, and then behind the femur should be you can kind of see the shadow of the patella. And then that is it for that. And then most of the time they take these projections because they want to see if there's any sort of ACL tear. And then for my last projection, I have the AP oblique medial rotation of the knee. And for this image, the patella should be completely rotated to the medial side over the medial condyle of the femur. And then you also want to see an open tibiofibular joint. That's probably the most important part. And that is about it.